Hi guys, my name is Sidra Ismail. I am in Health Information Online course. I'm here to talk to you about my semester on blog project. My blog project started out a little bumpy, but over time it refined in some ways, however, still a little ambiguous in other ways. One of the first things that I talk about was the pros and cons of the use of EMRs. I felt like a lot of people say EMR, 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 but what are the pros and cons? One of the discussion board I discussed that even though EMRs are good for individual hospital, but I do not feel that it's the best thing because we do not have one system, one database where we can look up every patient, every history, everything that you could possibly know about a patient. In emergency room settings, I run into this problem a lot where I have a patient who's never been here before, but I'm not able to look up their history. So the patient is unresponsive. So at that point, we have to go by what we think trial and error and what can work and what cannot work. And if he's allergic to something, we won't know about it until we give the medication, so on and so forth. So I felt like that was one of the things that we could work on. First, creating a database where you can have the information readily available for all hospitals instead of dividing the information within the hospitals. Recently, my hospital switched from Meditech system to Epic system to kind of be in the same page with the other hospital, our sister hospital, Edward Hospital, and now we have access to their data. However, we still do not have access to data from, say, CDH or Advocate, who also uses Meditech. Who also uses Epic. In those sense, I felt like even though emergency medicine it has came so far, at the same time, the medicine just hasn't come far enough. The accessibility of data is still pretty controlled. And I understand that, to some sense, we have to control the data. Other sense, I feel like if you have the proper credentials, if you have permission, you should be able to get just minimum amount of data like allergies and name, date of birth, and any past history, like any past medical history. Nothing that, if it's something related to mental health and you want to hide that should be one of your concerns, and you can do that. You can use that opt-in option to do that. You should hide that information. But things like allergies and other things that can help medical professionals to kind of treat you at the time, especially emergency situations, that should be readily available. One other thing I talked about within the emergency medicine was the SEEPS model, and talked about the level of education and how it affects the emergency room. So, say if there is a nurse who's been there for 20 years, but doesn't really know how to use the technology versus nurse who's a new nurse and does know how to use the technology. Within the hospital, we use a system called Rover, and we also use a system called AccuCheck to check patients' blood sugar and Rover before we draw blood and provide any medication to the patient. Before we do any of that, we have to scan patients' ID band to make sure that they are who they say they are, and we have the right patient. This can actually eliminate a lot of mistakes, and it assures that even the nurses, because everybody gets busy, so the nurse knows who the patient is, and the patient knows what medication they're getting, and so forth and so forth. With the use of that, now you have to judge between who would you hire, a person who is far more experienced, a person who is easy to learn technology. So those are the things I talked about within the SEEF model. One of the things I mentioned was, hang on one second. Sorry, I just had everything in the front and somehow I lost it. Okay, so one of the things I talked about was the environment. Another thing that we at Elmer's Hospital are pretty concerned about, everybody in every section, actually we used to, but not anymore. Every section we had a stop sign. It was an actual stop sign from, what you see when you stoplight, and then if the noise level went above the limit, the stop sign would turn yellow, and then if it went above yellow, like if it's louder, went above, it became red. That signals people, okay, quiet down. This is emergency situations. This is an emergency room, and we don't need all this laughs and stuff. Another thing I talked about was the organization and the organization part of the SEEP model, about the 12-hour shifts, 3 or 4 days of planned reorganization. Social relationship is frowned upon, however, not prohibited. Patient is safely indicated by posting yellow signs on the door. This just signifies like the kind of like the process it goes through. Like every patient is determined. Every patient is assessed for a fall risk. Every patient is assessed for any other situations that may cause them to fall or risk themselves in any way. Patient safety becomes a higher priority than anything else. That was another thing that was very important to me, and I wanted to reflect that within my bot project, that I did mention that in emergency situations, a lot of people think that we nurses are busy, nobody's looking after them, but there are checks and balances that from the moment a patient walks into the door till the moment they walk out, we have those checks and balances in place so the patient doesn't risk themselves in any way. Of course, that doesn't mean that the mistakes don't happen. Mistakes happens in every job, and this is the same thing over here as well. One another thing I wanted to talk about was my concept map. So I actually didn't know it was a rough draft for the concept map that we had to turn in, or I didn't realize that. So I actually made a concept map at the time, which I turned in. If you guys go to the concept map discussion board, you'll be able to see my concept map. But my concept map, I wanted to start by talking about the primary component to the last component that I mentioned over there. The concept map started out with the patient walking into the emergency room. Patient gets registered, like using the technology that we have, it creates their account. Each patient has an MRN number, an encounter number, and also patients are distinguished between with their date of birth and patient's name. Okay, so our primary keys are MRN and encounter numbers, and that's what I feel like. But some may argue that it's between patient name, encounter number, and patient date of birth, because we ask date of birth at least 16 to 17 times when the patient is in the ER, or in any part of the hospital for that matter. Once the patient's registered, they walk over to the triage room. The nurse triage them. So the nurse has, I want to say about 16 questions that we have to ask. Each time we ask those questions, we check a box. Then their vital, the EKG if they needed, initial assessment. Once they're done with that, the computer asks us, like the system asks us to assign them a level. Level 1, level 2, level 3, level 4, level 5. We have 5 levels. Level 1 would be somebody who's full arrest for unresponsive completely. Level 2 would be a chest pain, a GI bleed. Level 3 would be nausea, vomiting, diarrhea. Level 4 would be abdominal pain, fever. Level 5, minor injuries, sore throat. Level 4 would be minor injury, sore throats, and level 5 would be like suture removals and a rash, a small rash, or sometimes I've actually had people come in for a hangnail. That would be a level 5. So keeping that in mind, I made the concept map according to that. It is a very small concept map to what goes on in the ER, but I felt like this was the most important part because this part of the encounter determines how their visit is going to be with an emergency room, within the emergency room. They're either going to have to wait 3 to 4 hours to be seen, or they're going to have to be seen right away. I usually tell people if you have to wait long, that means it's a good thing because that means you're not dying. At the same time, nobody's pain, nobody's suffering can be compared to other people. Can be compared to another patient or whatever else. So we do keep that in mind, but at the same time, that initial encounter with the first person that you see determines like where exactly, what level, and everything needs to be. If that encounter doesn't go as planned, or that encounter doesn't happen as you wish, or you have lack of information in that instant of encounter, this is where the breakdown occurs. So when the breakdown starts at that early on of the encounter, after that it usually ends up being a whole domino effect. And this is what happens with patients who walk in with unresponsive, who come in unresponsive via ambulance, ambulance and EMS people. They try to grab as much information they can, but they are working with the littlest information as possible as well. This is just kind of like the overview of my vlog project, and I realized that I'm completely over time. If you guys have any questions, you can email me at Sidrah, SIDRAH_2007 or you can write it on the discussion board, and I will try to reply as fast as I can. Some of my blog posts didn't get posted because I had a lot of problems with the website. So if you want to see it, I can also post it on the blog post as well. If you wanted to know a little bit more, I can always tell you about that as well. Thank you so much for your time. Thank you so much for listening to me. Thank you. Bye.